Good morning, everyone, and welcome to UPMC Children's Hospital of Pittsburgh's first Digital Ethics Pediatric Symposium, where we will be discussing moral and ethical considerations within the pediatric digital healthcare space as it relates to the coronavirus and telemedicine delivery. My name is Samantha Williams, and I will be your moderator for this event. Just a reminder that through this Teams live event, even if your sound is on and you are unmuted, you will not be heard on the call. You may use the Q&A feature to the right of your screen to type any questions you may have, and we will leave time at the end of the event to answer them. This event will also be recorded and posted to the Children's YouTube channel and the event page after the presentations. So before we get started, I would like to introduce one of two of our hosts for this event, Dr. Ken Nischal. So Dr. Nischal is the Medical Director of Digital Health at UPMC Children's Hospital of Pittsburgh. He's also the Division Chief of Pediatric Ophthalmology and Strabismus, as well as the Assistant Medical Director at UPMC International, and lastly, the Co-Executive Director of the World Society of Pediatric Ophthalmology and Strabismus. So thank you, Dr. Nischal. I will now transition the presentation over to you to introduce our sponsor, our second host, and key presenters.
Thank you very much, Sam. Sam Williams has done a tremendous amount to put this together. So Sam, thank you very much. And Sami Shalevi is helping her today. Thank you. A big thank you to Lalit Chodia. He's our sponsor. Lalit is the founder and the CEO of FAAP Industries and a member of the Children's Hospital of Pittsburgh Foundation Board of Trustees. He and his wife, Supriya, live in Pittsburgh and have 3 adult sons, and they're great supporters of children's. Thank you very much, Lalit, indeed. If I could have the next slide, please. It gives me great pleasure to introduce my co-host, Amy Biller. Amy's the chair of Clinical Ethics Committee at Children's Hospital. She's director of the Ethics Consult Service here and the Ethics Facilitator for the Clinical and Translational Science Institute at the University of Pittsburgh. Amy, it's been great putting this together with you. Thank you for co-moderating with me. We've got an amazing panel today, and I'd like to give you a brief bio of each member of the panel and the actual speakers themselves. I'd like to introduce Andrew Watson. Andrew is a colorectal surgeon at UPMC. He's the co-founder of IBD Live. This is a national weekly grand rounds for complex IBD management. He's been the president of the American Telemedicine Association. He was program chair in 2018, has served on all the committees of the ATA for the last 8 years, and was elected fellow in 2020. He co-founded and co-leads the national tweet chat Telemed Now in early 2020, and he's one of the inaugural members of the American Board of Telehealth. Andrew, it's a great pleasure having you here today, and I look forward to hearing you talk. Can I have the next slide? Loretta Mateo is the Vice Chair of Diversity, Equity and Inclusion. She's Clinical Associate Professor, Division of Adolescent and Young Adult Medicine, Fellowship Medical Director of Adolescent Medicine, and the Director of the Transition Services Program, Center for Adolescent and Young Adult Health. She's also the Children's Community Pediatric Adolescent and Young Adult Physician Liaison. She's a real champion of telemedicine, but more importantly about the ethics and privacy issues, especially. Loretta, thank you so much for being involved today. And lastly, I'd like to introduce Kristen Ray. Kristen is Director of Health Systems Improvement for UPMC Children's Community Pediatrics. She's Director of the University of Pittsburgh General Academic Pediatrics Research Fellowship and serves on the American Academy of Pediatrics Committee on Pediatric Workforce. She's also board certified in clinical informatics. Kristen, great to have you on board. Thank you so much of all of you for agreeing to do this. So I'm going to basically talk very shortly about the evolution of telemedicine in the last year. Next slide. It's interesting, if you look at the background, was it an evolution or a revolution? You know, in 2016, 15.4% of US physicians had access to telemedicine interaction with patients, 11% had access to interact with other healthcare professionals. In 2019, despite 50 health systems having telehealth technology for home care, only 1% of rural populations in the United States had experienced it by the end of 2019. And by the beginning of 2020, only 24% of US healthcare organizations had a telehealth program in place. Next slide. What's really interesting is that when you look at a consumer survey done by Amwell now, 66% of those surveyed, and these were adults, of course, were in 2019 were willing to use telehealth. Only 8% had experienced it. 66% of respondents used personal health monitoring devices. So think about that. 66% in 2019 were using, whether it be a Fitbit or similar product to monitor their own personal health. Next slide. So what changed? Well, we all know it was the pandemic, but really this statement from the HHS changed everything. Under this notice, they covered healthcare providers were able to use popular applications that allow for video chats, including Apple FaceTime, Facebook Messenger video chat, Google Hangouts video, Zoom, or Skype. That really changed the game. It meant that all of a sudden, as the pandemic hit, access was suddenly opened up. There were certainly some platforms that you couldn't use, and those are shown below. And Andrew Watson's going to talk about the different platforms, which I think is really important. Next slide. So this was telemedicine at CHP from January to October 2020, and you can see the total numbers really rocketed during between March and May, and then have sort of started to stabilize. Next slide. I think it's important for us just to recognize that in terms of adoption of digital health delivery, innovators, early adopters, late adopters, and laggers all played a role. But the pandemic literature landscape fails to uncover any discussion about the natural behavior tendency of a provider with respect to risk. And if you look at early adopters, they prefer revolutionary change, they're risk tolerant, whereas the mainstream, if you like, the late adopters prefer evolutionary change and are risk averse. Next slide. So what the pandemic did was that the revolution in telehealth was the pandemic. And the reason it was that telemedicine ensured a protection against maleficence for our patients and also ensured to a degree economic survival. And that really crushed the risk aversion of, if you like, the mainstream of providers. Next slide. In terms of ethical, legal, and social issues, global national medical organizations and various scholars have ruminated over ethical issues in telemedicine for at least 30 years. But these were little addressed as the pandemic hit, especially for pediatrics. Next slide. So when we think about ethical, legal, and social issues, often referred to as ELSI, you've got quality of care, consent and autonomy, access to care and technology, legal and regulatory, clinician responsibilities, patient responsibilities, the change in relationships, commercialization of the actual platform, the policy of the institution, information needs, and then evaluation. In the next hour or so, we hope to be able to discuss this with you, and it gives me great pleasure to introduce Amy Biller, who's going to discuss the deployment of telemedicine in pediatrics during COVID-19. Thank you so much, Amy.
Thanks, Ken. So we can just advance to the next slide. So I'm going to be talking about the deployment of telemedicine in pediatrics during COVID-19. Next slide. There were two main pre-COVID policy recommendations from the American College of Physicians and from the American Medical Association's Council on Ethical and Judicial Affairs. Next. For the ACP, telemedicine comprises different types of technologies. And for the purpose of this talk, I'm going to be focusing on the second technology, the synchronous real-time interactive videos. Many of the 13 ACP recommendations really were focused on ethical issues, the use of evidence-based medicine, standards of practice commensurate to seeing patients in person, uncompromising ethical obligations to deliver clinically appropriate care, addressing the needs of all patients without disenfranchising financially disadvantaged populations or those with low literacy or low technologic literacy, and ensuring secure and private visits. Next. The AMA defined a continuum of clinical interactions and accountability, really ranging from those websites where physicians just provide content only to synchronous video visits with the same accountability we would have as an inpatient encounter, and also focused on access, patient-centeredness, privacy, confidentiality, physical exam limitations, and disruption of the therapeutic relationship potential thereof. Neither the ACP or the AMA guidelines envisioned the use of synchronous telemedicine for acute care for infants and children. Next. The AMA laid out visits that would not be well served by telemedicine. However, really acknowledged that for some patients, it may not be feasible to receive care in person. When the options are for a patient to receive care that may be less than ideal via telemedicine or not to receive care at all, then telemedicine services could be appropriate. Interestingly, the examples they gave were providing care to submarine crews and astronauts. And then COVID-19 happened. Next slide, please. Each stakeholder had different expectations and measures of success. We'll be focusing on patients and providers. For providers, the pandemic rolled out so quickly, many felt that telemedicine was a stopgap measure until we really learned more about the virus, secured adequate PPE, and changed the physical environment to decrease the risk of transmission. They had competing obligations to keep other patients in the clinical environment from getting infected, as well as their staff, noting that if clinicians and staff became ill, then clinical activity really would come to a halt. For parents, they were scared to come to the office, but also concerned about their children's health. And it became increasingly difficult for them to bring children into the clinical environment because of parameters imposed for infection control, like only allowing one support person, no additional children in the room, and even more difficult if they relied on public transportation. Also, rapid testing was not available on site and so limited the ability to make the diagnosis of COVID-19. Next, please. So what expectations were there prior to starting this whole experiment? So providers felt that they would largely be providing forward triage, meaning sorting patients before they arrived in the acute care setting, by assessing symptoms, exposures, maybe some physical exam findings, and also that some subspecialty care would be provided. For patients and families, it was unclear what their expectations were, but innovation in IT was already changing the way time and distance were perceived, and the pandemic really accelerated that process. Next, please. So how was this actualized? For providers, the forward triage was something that was able to be done with some level of competency. Some subspecialty care existed, and also these visits were good for some follow-up care. But for acute care, many providers really felt like this was the best that could be provided, but under the worst possible circumstances. patients and families kind of more of a hybrid visit, not quite a telephone visit, not a telemedicine visit. Part of the confusion really was because pediatric practices historically spend a lot of time triaging routine questions from patients. So some patients or families scheduled for telemedicine, but what they thought they were doing was just kind of calling in for a routine question for a nurse to answer. And so they were confused about the expectations of this visit. Some families didn't really set aside the same type of time that they would if this were an actual appointment. So often we're doing kind of simultaneous tasks because this was something that was occurring at home. Sometimes children were at a remote location. Sometimes parents weren't present. Administrators thought that these visits would enhance workflow, but many times they were disruptive to workflow, especially because we did not have that strong public health infrastructure, so spent a lot of time going over those more kind of public health questions. There are also limits of technology. The quality of the audio and video feeds often varied tremendously. But even with the best possible technology, there are problems with telemedicine visits. Generally, face-to-face encounters and interactions are more spontaneous, free-flowing, and actually faster. Nonverbal signals can often be missed on these telemedicine visits. And the impressions people form of remote others are different from and less positive than the impressions they form of face-to-face others. Next slide, please. So my colleagues will be speaking to matters of autonomy and justice, but I feel the telemedicine as implemented during this pandemic for acute pediatric care is not meeting the ACP nor the AMA recommendations pursuant to beneficence. And I do think that there are two critical questions. One, will we be able to put this genie back in the bottle after COVID until we have enough time to evaluate and implement it for the standards of the ACP and the AMA? And second, if telemedicine had not been an option during the first wave of illness, would healthcare systems have invested more robustly in other solutions like physical plant changes, PPE, increased staffing, in-office testing, that would have enabled us to see patients in person safely, efficiently, and competently during subsequent waves of the virus. Next, please. As physicians, we are also part of a moral community. Our defining purpose is to respond to and to advance the welfare of patients. This commitment invites trust, and we incur a moral obligation to honor that trust. But what happens if we are prevented from keeping that promise? Next. Jameson described moral distress in 1984. It often arises from hierarchical differences within the medical system, so it's often experienced by nurses and in critical care settings. It occurs when a clinician is constrained from acting in a way she feels is morally correct. Many factors unique to this pandemic, including the lack of preparedness of the national public health system, have resulted in unleashing a completely novel mode of care on pediatric providers that constrains them from providing their usual standard of care. Many realize this is the best and often only option at this time. However, if this model continues beyond COVID-19, we may start to see increasing moral distress as many providers begin to view this as an affront to their personal integrity. Next, please. And actually, we can skip that slide, Samantha, in the interest of time. So, next steps. I think our top priority, and we're setting priorities, is really to ensure that post-COVID accuracy of diagnosis and treatment is commensurate or superior to in-person encounters, which are the gold standard. patient outcomes, not satisfaction or efficiency, should be rigorously evaluated. And there should be strict guidelines outlining the boundaries of telemedicine practice for pediatric patients. These should be established and adhered to. Thank you.
It gives me great pleasure. Thank you, Amy. That was wonderful. It gives me great pleasure to introduce Dr. Andrew Watson. Andrew, I'm really looking forward to this talk, and I thank you very much for taking time out of your busy schedule to be on the panel today.
Ken, thank you very much, my friend, and I have the highest respect for you and all that you do at Children's and also for Children's Hospital. It truly is a remarkable institution. And I'm also very appreciative of what Lalit's doing in sponsoring this. Lalit's also a great friend and appreciate what he's done as well. Next slide. It's a very interesting time for us in healthcare. I'm a colorectal surgeon. I now use video cameras and sticks to operate on patients. It's called laparoscopy. When we started doing that in 2003, it was the exact same discussions we're having now with telemedicine. We were told it was heresy, evil, witchcraft, and bad for the patients. It is now the standard of care. In fact, if you weren't to offer a patient laparoscopy, people would probably question your medical training and even my surgical training. So laparoscopy is the same thing as telemedicine. What's different about this right now is that a face-to-face visit has been the standard of care, but right now even that's up for debate. With the consumer electronics market and with all that we've learned about telemedicine, I'm quite convinced that in the next 3 to 5 years, over half of medicine will be done with telemedicine. It's just the evolution of our society and the evolution of our world in the digital era. So COVID had an enormous impact on telemedicine that's net spectra positive. Next slide. It is hard to believe that 5 years ago, the AMA thought telemedicine was unethical, but we learned it was the only avenue for care. We saw it at scale. A lot of people learned about this, operations, nurses, doctors, administrators, and policymakers. Next slide. Without a doubt, there are unintended consequences, and this leads into the platform discussion, Ken, but we saw an increase in disparities. It was very hard for education. We saw persistent challenges with interoperability, and we saw delays in care. And the delays were not about telemedicine, it was really about COVID. Next slide. But fundamentally, what we must recognize is that telemedicine is not monomorphic. There are 3 different groupings of platforms. When I was president of the American Telemedicine Association, we had these existential discussions. What is telemedicine? And I see 3 large categories. In the upper left-hand side, you see this traditional form, rural clinics, emergency care, stroke care, dermatology, pathology. You know, effectively, all of radiology is telemedicine, right? And so that's now very interesting how far it's come. Psychiatry is where telemedicine started here at UPMC in 1999. So this whole traditional platform is a mix of live video and store and forward, but it really brings to bear and shows us how much we've learned in the last 2 decades. In the upper right-hand corner is the synchronous live video calls. We use My UPMC, VidYO, we use American Well. This is a global process. These are global, very well integrated platform companies. But this is synchronous live video right to your cell phone or smartphone. And this is very important to understand because healthcare did not create synchronous visits. Google, Apple, Verizon, Amazon, FaceTime, these are the tools that were creating live video. And so now we don't think about it all turning on a Zoom call or a FaceTime or a Skype. We do it actually for a living and for our education. So synchronous live video came to healthcare in 2015. It's because of consumer electronics, which by the way are not slowing down. In the last bucket of telemedicine is asynchronous, really known as remote monitoring, where it's a process of gathering data from home, you interpret it centrally, and you can react to it. So there's 3 big types here, and they all come at different times. But the point is, this is the evolution of one of the largest revolutions in healthcare, in that we're learning you don't have to have a face-to-face visit all of the time. It's just like laparoscopic surgery. Most of the time, the majority of time, the vast majority of time you can do it, but it's not all of the time. There's never an absolute in our lives in healthcare. But again, the consumer electronics market is pushing us forward. When's the last time any of you voluntarily left your cell phone at home? That's how far we've come. This is how far we will go. And these platforms are powerful. Next slide. I think we're going to see that these platforms change. Traditional at the bottom will always rise in importance, but you'll see a rebalancing in 2020 and beyond of the synchronous video visits and monitoring. Many of us feel that remote monitoring will probably be the dominant form of telemedicine moving forward, and it could plug gaps in care, primary care, help to support subspecialty care. I don't have too much time to get into it, but just the point is these three platforms are balancing right now, and they're going to change and evolve over time. And traditional telemedicine, radiology, pathology, psychiatry, I mean, this is going on every day. Live video visits are now urgent care, on-demand care. I've done about 600 live video visits. I'll be teaching medical students later on doing telerounding. I've rounded from around the world. I've done clinics from Oslo, clinics from New Jersey, and clinics from my home. The patients love it. Remote monitoring is coming soon. We're doing a fair amount of it here, but much more to come. So again, these platforms are evolving. Next slide. And I just want to highlight, and Ken and I have talked about this, that these platforms are changing. Fortunately, there's consolidation. You're watching a company called Teladoc, a live video platform, has now bought InTouch, a remote monitor company called Livongo, another company called Best Doctors. So instead of having pieces of the car, they're bringing it together and synthesizing it into something that's easier for us as physicians and other providers to use. American Well has purchased Avizia. It also just went public in early September. And again, it's another world-class live video platform. We actually use it here at UPMC. And MD Live, another video platform, is out for an IPO. But what's interesting is during COVID, the regulations around these were relaxed. As Ken pointed out, we could use other video platforms, TikTok, Skype, FaceTime, and the like. So you're seeing also on the monitoring side, a lot of changes with Amazon creating, building, selling bioperipherals. You're watching other companies. We use Vivify, Twistle's another. The whole monitoring space is rapidly evolving. Again, trying to keep up with the consumer electronics market. So the platform companies are changing, they're evolving, they're consolidating, and this is a hard process to watch, but we are. And I really respect the work of Mark Sevko and Ken and many others in trying to keep up with this process, as are many of us here at UPMC. Next slide. And so as we go forward and as we innovate and as all these platforms, you can see these red arrows move us forward, there are some considerations. Next slide. First of all, Ken points out, where's the data? So what happened is during COVID, Health and Human Services oversees the Office of Civil Rights, and they enforce HIPAA. And they also look at fraud, waste, and abuse. That's the alphabet soup I list here. They relax the standards, and they let us use non-HIPAA compliant platforms, Skype, Doximity, other things that were really coming into the forefront. Where's all the data? Where's the service level agreements behind that? Where are the standards of care behind that? And it's a big question that's coming up. There's a whole different view about data sharing and interoperability coming up right now. But these platforms that we're using, they're not all HIPAA compliant. And so the public health emergency is set to expire about 1 or 2 days before or after the inauguration. If the public health emergency goes away, and a lot of these platforms that we've typically used can't be used, then what happens? But there's a lot that we're going to learn from these companies, from the data, the transactional data, about this type of data and how it was used. And so I think if you look at these bullets, the platform data, where is it? We know it, but do we have access? The HHS, OCR, and HIPAA is going to become very central in the next 6 months, 2 to 3 quarters at least, about these telemedicine platforms. And we're going to learn a lot about the new data trust and sharing rules. And also understand the last bullet point. The states control the standard of care, and they need to relook at the standard of care. Why is it that patients drive from Ohio, New York, Maryland, and West Virginia to see me for care, but I can't do telemedicine in their states? It's perfectly acceptable for them to drive to see me, but I can't save them the cost, the risk, the pain and suffering of travel because I can't do telemedicine in those states. So the states are going to have a long, hard look at their moral fiber and the ethics, because telemedicine across state boundaries should be routine and commonplace. It's what the patients want, and it's safe care and humane care. Next slide. And so I just want to thank you for the time. It's a very interesting time in telemedicine. The platforms are evolving. And again, I want to highlight behind this is the consumer electronics market. It is not a single person, a single country, or company that can get in the way of the combined forces of Apple, Amazon, Verizon, Google, Samsung, and the like. That is a force that is to be reckoned with. I think they control 60% of the S&P. But I want to thank you for your time. You can feel free to follow me on Twitter. Happy to keep this conversation going. And again, I want to thank you, Ken, for the opportunity. I have the highest respect for you and all that you do. Happy to answer any questions.
Andrew, thank you very much. I hope you'll stay on. Amy and I will be moderating the questions that are coming thick and fast in the chat box when everybody's spoken. But before we get to Loretta, and I think Loretta's talk is really going to open up some really important thinking points. The first thing I want to say is, none of us have a financial interest in any of the products that have been mentioned. I do want to just say a couple of things. I spent a lot of time in the last 2 days reading the confidentiality agreements that I've never read with any of my Apple products. And actually, Apple FaceTime do say that they do record data. They record data about who called, how long the call was, in terms of the IP addresses that were made. They say that they don't hold any of the data. Doximity dialer, some of you might be using that. They say very clearly that they will take your data and they will share it with third-party companies in terms of other products, what you were using as to do the call, and also there's about several things that they share your personal data with. They don't anywhere discuss whether they share any of the patient data. I presume they don't. Zoom, as you mentioned, was okayed by the HHS to be used, and I'm sure other companies have had problems. Zoom allegedly have had encryption issues, which they say they fixed, where the transmission was not secure. So just before we move on to Loretta, Andrew, what's your take on that? I mean, we talk about the platforms. If a health system has their own platform and we have ours, we use VidYO that's embedded into our EMR, that's secure because we have a firewall, right? But what about these other platforms? Do you think providers and patients realize or understand that data, even if it's not the actual call, that data is being stored by some of them?
Fundamentally, no. We were in crisis mode during COVID, as was all of our society. I don't think that we're going to have a true view of this for at least 6 to 12 months afterwards. And one of the big issues that's governing these platforms is FDA certification. And this is why Apple does not want to become a healthcare company, because they don't want to have their cell phones be FDA certified, because there's a huge process and a lot of regulatory limitations behind that. So there is regulatory pressure on these platforms, some of them, to keep it clean. But there's a lot going on right now that we need to learn about. And frankly, we have to learn about. And I see there's only 2 ways that we can do it. One is to do it and learn from it, or the other is the slow dental drill of taking 2 decades like we just did and trying to figure it out. So I think it's very positive and a little bit the tragedy of this pandemic goes beyond any words that I could put together. But the only silver lining is it forced us to take a long, hard look at how we practice medicine and what tools we have. And a big tool is telemedicine, and we're going to have a good hard look at these platforms. It is remarkable how few lawsuits there are in the history of telemedicine. So I'm very optimistic that the regulatory community and the provider community and the patient advocacy community and patients themselves will come together to learn about it. And I think the fact you're highlighting it is absolutely brilliant and is extremely important. But much more to come. There's a lot of smart people in this field, and there's also an enormous amount of private equity and venture funds in this field, and they're going to be watching this very, very carefully. The capitalistic side will be very important to how this is governed. So I'm optimistic, but again, you're bringing up great points, Ken.
Thank you, Andrew. So I'm sure we'll discuss this more in the later on. So Loretta, Matteo, Loretta, thank you so much for being on the panel. We look forward to your talk.
Thank you, Ken, and thanks to everyone here. And I'm really happy to be among this group to talk about confidentiality and ethics in telemedicine and adolescents, near and dear to my heart. It's always interesting to talk about a topic when there's not much in the literature about it. So next slide. So the ethics to me in telemedicine is about access and confidentiality, and Dr. Ray is going to discuss access, and I'm going to talk about confidentiality issues about state law, unintentional disclosure, and the portal. Next. So why do we need consent and confidentiality for our adolescents? This is a very important subgroup in pediatrics. Well, it's because we want them to have autonomy. We want them to learn about self-determination in their healthcare decisions. It's important for us to have effective risk assessment, and we want to have a therapeutic relationship with them. Next slide. So it's essential for good care. It's essential for being able to transition to adult care. And most importantly, that bottom line, compliance with state and federal law, which we all want to do all the time. Next. So it's also a moral obligation in my mind. Confidentiality increases disclosure, and without confidentiality being secured, teens will not disclose. And if we have time later, I can tell you about a very poignant story just about this. Next. So when can a teen be treated without the presence or active permission of a parent? Click. So what it really means is, when can a teen have a confidential appointment? Next. So first one needs to decide, can this teen legally consent to care? And then click. Once one decides that, that teen then has control over that information, and that means that they have confidentiality. Next. So in Pennsylvania, the law, the age of majority is 18 years. There are all these exceptions in terms of emergency care and emancipated minors. Next. But in Pennsylvania, we actually have more to this. Next. PA law permits minors to consent to certain medical services: contraceptives, testing and treatment of pregnancy, STD care, drug and alcohol treatment, mental health outpatient care. Next. It's important to know, though, that for abortions, we must use bypass. If a teen wants to keep this confidential, you must go before a judge. Next. Also, I tell my patients when they're talking to me to remember that PA law says who can have sex with whom at what age, and in Pennsylvania, that is age 13. Between 13 and 16, a partner may not be more than 4 years older. Next. So it's very important that we maintain confidentiality, and that means sometimes we have to protect teens from themselves. Next. So enter telemedicine. So, telemedicine, is when I very first started doing it, was not all that different than a traditional visit, in that the teen was in a secure place, the originating site, and I was at the distant site. So we had 4 walls, we had confidentiality. Next. But then enter COVID. Next. And enter CMS relaxation of rules. HIPAA, as we heard, had platforms were being relaxed, and reimbursement rules were changing, and most importantly, in adolescent, for our folks, entered direct-to-consumer telehealth. Next. So here we are. We're trying to keep our teens' health care confidential. We have the EHR pre-portal. We have the portal that we have. We have then portal with embedded e-visits, and of course, we have the native platforms that we were hearing a little bit about before. Next. So what does the American Academy of Pediatrics tell us? Well, their policy statement on this points out that there are no federal guidelines for HIPAA and health electronic records. It's left up to the states, but we do know, of course, that we need to assure confidentiality. Click. And basically, it's the wild, wild west. Next. The AAP goes on to say that there are no standards currently for HCR technology to ensure confidentiality. What happens if a state is silent on confidentiality, and who has access to the records in terms of a parent, teen, and legal subpoena? Next. And then we have a whole bunch to add to this mix. There are different state laws for disclosure or mandated reporting. There are differences between a young 12, 13-year-old and a 16, 17-year-old. And the differences are also based on the type of care we're providing. For FRCOphth in the state of Pennsylvania, a minor can come to me for confidential care. Any age, there is no bottom. However, there is disclosure so that if a 12 or 13-year-old wants to have reproductive health care for contraceptives and they're having sex, I do not have to tell their parent if they say no. However, I do have to report that to CYF. For mental health, there is a bottom at that age is 14. Substance use and treatment certainly is hobbled by the need to have parents pay for it if it's inpatient. Next. So Barney and their group at the UCSF had this article in the Journal of Adolescent Health. They talk about their successful expansion of telemedicine during COVID. Within 1 month, they ramped up from 0 to 97% telemed visits. I would like to say we did the same in our division of adolescent medicine. Their group just got to the journal before we did. So they noted that it was successful, but there were barriers, of course, and those were patient and provider acceptance, technical connectivity challenges, infrastructure to support HIPAA-compliant care, and unavoidable deviations for clinical standards of care. Next. They also note, of course, that there remain unanswered confidentiality, quality of care, health disparities. Next. So telemedicine guidelines are well established for general care for adolescents and peds, mental health, but not for telemedicine guidelines. Next. So the services that we provide typically in adolescent medicine are just fraught with confidentiality issues. Repro health, eating disorders, substance use, gender care. Next. And if we drill down a little bit and look at our transgender youth, one of our most vulnerable populations, Dr. Sequeira and Kidd, Dr. Sequeira, a former fellow, Kidd, a current fellow, they are working in our gender clinic here and put out this article and surveying their patients. Please note that trans-identifying youth are about 2% of the population at this point. And the majority of patients who come to our gender care clinic are traveling more than 30 minutes. The majority were open to telemedicine. The highest proportion of those who were open to it were those who had low parental support. So this was incredibly important for these very vulnerable teens. And you will see on the chart on the right that the teens really wanted to use telemed for those constant back and forth visits that really don't have high yield in terms of complexity, refills for their hormones, knowing about labs and regular checkups. Next. This is another survey that was done by one of my fellows. This is unpublished data. She did a qualitative survey in our gender clinic, and these are the themes that came from the youth themselves. They were, in fact, worried about confidentiality could be breached during a telehealth visit. They were worried about household members overhearing the visit. They were worried about the visit being recorded or Zoom bombing back in the days when people were doing that. And some would be hindered in asking about certain concerns because they feared that someone would overhear them. But they had suggestions, and these are suggestions that we use ourselves. Headphones. I like my teens to always have a headphone set on when they are having a visit with me. Messaging is something they brought up, that we don't have a chat function in our Epic e-visits that are embedded, and then obviously our texting is not secure. They wanted us to continually check in with them during the visit to make sure that things were still, and also to ask to see the room. And this is something occasionally that I will do. I will have the young person do a pan around, a 360 of the room to let me make sure that there is no one else in there. And then click. There are two other things that I will add to this myself. I often find myself in a situation where I can only ask yes and no questions. Sometimes I will have a teen have a noise machine if it's very difficult in terms of privacy in the house. Next. So we need to maintain confidentiality and protect teens from themselves always. Next. But the thing is that our teens are digital natives. They want privacy, but at the same time, as you can see from the graphic, they are constantly sharing their data and not really reading any of those disclaimers about what data is being taken. And so we need to protect them, but understand that they are out there and they are on telemedicine and they're sharing their lives. Next. So this couple of Google images, these are depictions of real visits and some ethical concerns and privacy that came up for me. The one on the left, I connected for a telemedicine visit. I click connect, and suddenly I find myself in a car. This teen happened to be driving, was a female teen with her mother, but this was the image I found on Google Images. And so, of course, I had them pull over before we had the visit. And then more likely, I see this over and over again. I click on connect, and I am suddenly in a car. Sometimes the car is pulled over. Sometimes the parent is still driving. The teen is maybe in the back seat. And one is thinking, how am I having a private, confidential visit? One is not. But in adolescent medicine, we deal with harm reduction. And sometimes things are a little bit suboptimal for us. And if this is the only time I can get this young person, I will have the visit, but then I will tell the family, next visit needs to be in a place where I can confidentially speak with your teen. Next. So these two depict two recent visits that I had. On the left, actually this was an early on visit. It's a young man, but this was a young woman, and this was early in COVID, and I am talking to her on a telemed visit, and in the middle of the visit, she suddenly says, oh my gosh, I have to go to the market for my mother. She's going to kill me. I completely forgot. And before I can say anything, she pops her headphones in, and her earbuds in rather, and walks with her laptop out to the store with me. And I said, listen, let's reschedule. No, I can't do this another time. There were repro health issues going on. And so I switched to yes, no questions. And she walked with me through the supermarket and back to her house. It was pretty mind blowing. Graphic on the right, young woman smoking. This was a visit I had just on Tuesday. I had a young woman I was trying to get a hold of for many months about medication issues. Finally see her on my schedule. I click connect, and she's in the middle of a class. And so I said, well, okay, we have to reschedule. And she said, no. She put on her mask, which had been off, went up to the teacher and said, hey, I have a visit with my doctor right now. I'm going outside. And outside she went, took off her mask, lit up a cigarette, believe it or not, and we had this visit. And so the harm reduction, I really needed to talk to her about her medications. And I didn't take the time to talk about the smoking because I was just trying to get one thing done. Next slide. So there are positives, however. Next, click. So, oh, she's asleep. Well, you know what? It's really great. When they're asleep, we can get them up and in front of a camera and have a visit. We forgot about the appointment. No problem. I can switch the appointment to another day and time that is mutually convenient, and I don't have to worry if I have an MA or a room in the clinic. I have to watch these kids. I've had parents tell me this, if I had to drive my teen to your office, we would never have had this visit today. Next. So successful integration of telemedicine for care for AYA requires knowing the limits of telemedicine, which means knowing all about confidentiality, but we have to be creative and rethink. We can't let the perfect be the enemy of the good, especially during COVID. Next. So sometimes holding on does more damage than letting go. Next. And the AAP and the Society for Adolescent Health and Medicine reminds us that there is, we have overt issues with confidentiality, but there are inadvertent disclosures that we must guard against as well. Next. So this is a slide obviously from a Field of Dreams, and if you build it, they will come. In terms of confidentiality and EMR, if we don't build it, providers will go around it. And this was a study by Stablin and their group looking at confidentiality in electronic record. Next. So what they found was that practices where confidentiality was not ensured, there was selective omitting or concealing of information. And I think we can all agree that that's not a good thing. Next. So what we have here and I deal with is the portal through Epic. And I always say beware. Full teen access means a parent can see everything in the electronic record, and limited teen access means they can see some things. And if you see here on the right, some of the things they can see are allergies, the growth chart, and wellness tracking. So if I'm treating your chlamydia confidentially and you have the rare allergic reaction, it is quite rare, I have to put that on the chart. So your mom or dad may wonder, why is that on your electronic record? Next. And these are, this is not meant to be read. This is meant to give you the impact. These are all the things that a provider must keep in mind when they are seeing a patient and they're using the portal, because some of these things can be seen by a parent and some of them cannot. Next. Inadvertent disclosure. So chief complaint on a schedule, routine calls for confirming of appointments, the electronic, the explanation of benefits, calling for lab results. Just sitting in an office can be a problem. And so this is, a little bit easier with telemedicine, that your nosy neighbor is not going to see you in your doctor's office. Next. So what do we do here in Pennsylvania for a teen needing a confidential visit and not having the explanation of benefits go home to the parent? We are very lucky to have Adol Health, and it provides free confidential care for sexual reproductive health. Next. So telemed versus no telemed, access versus no access. Evans and their group, their feeling was, given thus far the demonstrated positives, it would be an inequity to go back. We obviously need guidelines to be developed, but one thing is certain, moving forward, now that patients and providers have experienced digital technology for healthcare, schools, social connections, telemed is here to stay. And I would say, in terms of ethics and confidentiality, click. Now that it has been done to take it away, to take telemed, a tool, it's not the whole toolbox, this would be unethical in my opinion. It would be moral malpractice, but clearly we need more research and guidelines for adolescents and young adults. This is critical. Next. So we don't want to resist change, we want to embrace it. Thanks.
Thank you so much, Loretta. I just wanted to clarify that the images that Dr. Mateo was showing were proxy pictures. They weren't the actual patients, they're proxy pictures from Google, right, Loretta?
None of those they were just pulled from Google, and they were ones that need a license. They were non-licensing ones.
Perfect. Okay, so it gives me great pleasure to introduce Kristen Ray. And Kristen, I'm really looking forward to the discussion of access, equity, and justice in digital health. Thank you so much.
Thank you, and thank you all for the chance to be part of this symposium today. I have to start by saying I am not an ethicist, but I think critically about issues of access and equity in my work as a pediatric health services researcher. So if you could go to the next slide. Before diving into a discussion of telehealth access and equity, I wanted to start with a definition of health disparities that comes from a 2011 piece by Dr. Paula Braveman and colleagues, in which they define health disparities as systematic and plausibly avoidable health differences adversely affecting socially disadvantaged groups. And they then proceed to detail key ethical values and principles underlying the importance of addressing health disparities, which include the principles and values that all people should be valued equally, that individual health has value both for individuals and for society, and that the resources to be healthy should be fairly distributed. Next slide. These ethical mandates to address health disparities have translated into multiple important calls to address health equity, including making their way into the Healthy People 2020 guidelines, as well as the 1976 UN International Covenant on Economic, Social, and Cultural Rights, which states that we should recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, and points out the need for the creation of conditions which would assure medical service and medical attention to all in the event of sickness. Translating these, next slide, translating these underpinnings to thinking about digital health, I think to start, I wanted to lay out some key questions around telehealth access, equity, and justice. And so one of those is thinking about what would fair distribution of telehealth look like? The default, if we don't think about this intentionally, is that often new services are rolled out and most accessible to those with the greatest resources. But if we think about it carefully, that probably is not where we most want to make sure telehealth lands. So alternatives would be to seek to distribute access to telehealth equally to all, or preferentially to those with greatest access barriers or greatest need for increased access to care, or perhaps preferentially to those with the greatest healthcare needs. And then a parallel question, perhaps looking at the same issue from another angle, is what does equity in telehealth look like? Is it ensuring equal access for everyone to some degree of telehealth? Is it equal access to some minimum standard of telehealth or high quality telehealth? Or would we be satisfied with a world where everyone has access to either in-person or telehealth care? You know, thinking about how these different systems lay on top of each other and what is the goal? Or, should we focus more on kind of a functional outcome in terms of not the question of access, but actually realizing optimal health for all? So to delve more into these questions, one thing that I think is important is to deconstruct the idea of access to care a little bit. And there's many frameworks out there. I wanted to start with from Pachansky and Thomas in 1981, where they lay out these 5 A's in terms of thinking about access to care. And so those include availability, which is having the personnel and resources; affordability, which is having costs that are that a patient is able and willing to pay for the services needed. Accommodation is about the clinical operations, such as issues of hours and scheduling processes. Accessibility in traditional thinking about access to care has been primarily about the ability to physically get to care. And then finally, acceptability is the idea that the care delivered, there is comfort in the care and the quality of care at both the clinician and patient level. When we apply this then to thinking about these domains across telehealth, the two that most immediately need some redefinition is availability and accessibility, where having the technology and being able to reach each other through the technology becomes really important. And so that is thinking about on the clinician and the patient side, having adequate Wi-Fi access, having adequate devices to connect, and then having the computer literacy that is needed to navigate this new way of moving through care. And while we may not need to change the wording of the affordability, accommodation, and acceptability domains, those are still clearly very essential for making sure that telehealth is accessible. So is it affordable? Are scheduling processes and the hours appropriate? And is the care, does it feel acceptable to the patient? I wanted to talk through those main ideas, but then also share with you my favorite conceptual model, which is from Levesque 2013, their patient-centered access to healthcare model. And you'll see the ideas we just talked through translating into here, but this talks about the general idea. I'm sorry, next slide. We're on slide 8 now. This talks about the need for care seeking as a continuum of care, where we start with a patient having a healthcare need, perceiving the need for that care, seeking that care, reaching that care, and then using that care and having the consequences of that care. If you advance one, that will lay in on the top of this figure the system side factors that influence access to care. And so you'll see many of the same domains that we just talked about in terms of availability, accommodation, affordability. These are what healthcare systems, clinics, clinicians potentially have control over. And then if you animate forward once more, on the bottom side of this figure are the patient side factors that have to do with health literacy, trust and expectations, mobility, social support, the ability to pay, and the ability to engage in care. And so each individual patient comes with a different balance of these factors that may make care within the same system more accessible to one and less accessible to another. If we animate forward once more, I started to overlay a couple of the dimensions that become more important as we think about access to digital care. And so down under the ability to reach on the patient side, again, are those issues of having the Wi-Fi devices, the computer literacy. Animate forward one more. On the system side, the apps and the expectations in terms of having the patient portal registration, or having the Wi-Fi or the device capabilities and available memory, and all of those become our system side factors in terms of the expectations that are set out for patients. And if you animate forward once more, when we start to think about digital care, then I think the questions around health consequences, healthcare consequences, we have to be very clear and explicit about what the comparator state is. Are we talking about what is the consequence of using this care, this digital care, in contrast to in-person care, or in contrast to no care? Because both of those may be plausible alternatives to telehealth care depending on the scenario. And then in addition to thinking about the consequences at the patient level, the last question to extend all of this, animating once more, is the question about, has layering telehealth access on top of in-person care access increased or decreased overall population equity and access to care? And so if we go forward to the next slide, starts with geographic and digital accessibility at the top. I just want to lay out three single slide examples of the complexity of how access is playing out and can play out as we roll out different levels of telehealth care. The first of these kind of little snippets that I think are really conversation starters. The first is by Coleman Drake, who is at the Pitt Graduate School of Public Health. And this is an analysis that he and his colleagues did looking at the overlay of broadband on top of in-person physician access within the United States. And so these two maps on the left show counties with inadequate primary care physician access, and on the right, counties with inadequate psychiatrist access. Those that are in white, or that may appear gray on the screen because of the scale here, are counties that had adequate access to in-person care. And so those that are colored anywhere between red and blue are those that had inadequate access to in-person care. So that for those counties, they shaded in the broadband capabilities there. And you'll see the counties with the dark red showing up have 9% or less of the individuals living in those counties having adequate broadband capabilities to maintain telemedicine. And so I think this just lays out that we know there's disparities in access to in-person care, and unless we are intentionally chipping away at these additional issues of digital accessibility, we may be layering multiple levels of inadequate access for some communities where other communities now have kind of dually enriched access. We go to the next slide, titled Geographic and Sociodemographic Disparities. This is analysis I did with some colleagues looking at across 12 state Medicaid programs in the pre-COVID world. When we identified children who were seeing subspecialists who used telemedicine, which children did they use telemedicine for? And if you advance two, then you'll see that the odds ratios show that children with traditionally geographic barriers to in-person care, such as those living in rural counties, those living at great distance to academic medical centers, those children had increased odds of receiving a telemedicine visit at least once over the course of the year while they were seeing these subspecialists. And so if you advance one, that I think is an example of how telehealth is being layered on top of differential access to in-person care to kind of equalize to some degree or move towards greater equity in access on a geographic level. However, if you advance once more, under looking at child race and ethnicity, we found that even after adjusting for geographic factors, children who were identified as Hispanic or Latinx, for example, had decreased likelihood of receiving a telemedicine encounter from these telemedicine providing physicians, and that we knew from additional analysis within these data that those children were also less likely to receive subspecialty care. So rather than equalizing care through telemedicine, this, if you advance once more, is an example of further widening disparities in access and utilization on by race and ethnicity. So forward one more, this is the last of three kind of snippets to just kind of open conversation. This is to think about access through different telehealth types. And so I know one of the ideas in terms of expanding access, given the issues with connecting on audio video technology, one option is to think about, well, should we allow telephone only encounters? And certainly some states, some communities, some systems are doing that during this time or in other settings. And so this is an analysis from the University of Missouri, where if you advance one, they found that children who, or those when both audio, video, and audio was offered, individuals who were more advanced in age were more likely to receive an audio-only visit. And then if you advance two more, that also more likely to receive an audio-only visit were individuals identified as Black or African American in this analysis, and individuals who were insured by Medicaid. So advance once more, this poses some important questions about, so there's clear variation by patient demographics and characteristics. Should we interpret this as warranted or unwarranted variation? Is this, a good or a bad thing? And some ways to think about potential interpretations that I think we need to dive in more in thinking about what we're doing with setting up systems. One question is this increasing access and making an option available to people who otherwise would not have an access? Or are we perhaps accommodating preferences? So we're giving more choice and people are choosing what they want. But a third interpretation might, hinges on the degree to which we think audio only and audio video visits are equal in value. Because if they are not equal in value, then the alternative interpretation here is that we may be systematically delivering lower value care to some individuals. And the answer to that final question might depend on the clinical circumstance. There may be some circumstances where audio only is really all you need, and others where without the video, there is a quality concerns. And so I wanted to move forward one more slide. I wanted to share those 3 examples as ways of just opening up the complexity of thinking about access and equity as we're laying out this digital landscape. And then my 3 final implications of all of this. One is, I think when we're thinking about access and equity through telehealth, I think the first thing we need to focus on is making sure any telehealth care that we're offering is high quality and high value. Because if it's not, then pushing for equitable access to low value care is questionable in terms of its value. So we want to make sure telehealth care is high quality and high value. And that involves thinking about where telehealth can meet the in-person standards, so you can do all the things you need to do for that patient through telehealth. And then conduct ongoing quality improvement and quality assurance to inspect and interrogate your practices. Another is to embrace opportunities to redistribute care through telehealth. And this will involve intentionally centering populations that are least well served by existing healthcare delivery systems in our design of telehealth programs. So think about the families and the patients who are not coming in as much as you would hope, or who are more often having no-shows for in-person care, and think of, talk to those communities and think about how can we build telehealth that will serve you best. And then finally, we need to embed equity metrics in evaluation of telehealth. And the key concept here is that if you're looking just at one metric of percent of patients who are having a visit, that can improve over time while disparities still widen. And so we need to intentionally identify equity-related measures and goals in any quality improvement or quality assurance work that we're doing within telehealth. So thanks for the last slide. Thanks for the time and chance to talk today. And I look forward to the additional conversation. Thank you.
Thank you very much, Kristen. That was superb. Kristen, before you go, there's a question in the chat box specifically for you, and I want you to answer this if you wouldn't mind. Anonymous says, for the socio-demographic slides, is it considered a plus or minus that different ethnicities received remote care? Not clear point in your message. Do you want to clarify that for the one of the audience members?
Yeah, I think that my first thought is going to be it really depends. And I think bottom line, it's going to depend on is this high quality care, and is this how does this compare to the alternative? And so I think if there are children who are not able to access in-person care because they live at distance, then if we think that we can deliver the same quality care through a virtual means, then doing so would be great. If there are children who are not, who we know are underrepresented in in-person care, and they're getting underrepresented in telehealth care, that is concerning. But I think it's layering on thinking about both the quality and the issues or the degree to which there is equity in in-person care as well.
Thank you. That's great. Could I ask everybody to switch their cameras off, but keep your mics muted until you want to say something? Firstly, I want to thank everybody. I think that this has been really quite extraordinary. There's a question in the chat box, and the question is, do we want to put it back in the bottle? So I'm going to go to all the panelists, but first I'm going to start with my co-moderator. Amy, do we want to put it back in the bottle? That's the question.
So I will say not all of these visits, no. I do think that, and because that was the phrase that I used. So I think that, and what I was addressing was kind of primarily these acute care visits in pediatric patients, most of them in much younger patients, and occurring, in the home, that was really kind of thrust on us in this COVID-19. But we already have a lot of evidence for where telemedicine works well. A lot of the evidence is in adults. I think, UPMC has for years has had a stroke program for ER patients that has been very successful for patients presenting to remote EDs outside of the main hospital, with neurologists on call to really manage the care of those patients remotely. Now, that is not a visit where the patient is at home and calling in. That is something that is mediated by another clinician. I think, in terms of PICU, NICU kind of remote help from from large ICUs to where there is a hospitalist there. I think that those can be helpful. I think we found out even when we started on this, that there are some visits, behavioral health, that really has taken off tremendously for telemedicine and really has increased access for a lot of patients. Likewise, at our institution, those complex care patients, a lot of those visits for telemedicine, where it's very difficult to get those patients into the main kind of hospital environment, has been successful. But I do think that this experiment for doing this, we need to make sure that we can maintain the standard of care. And I'm speaking in pediatrics specifically of acute visits. Well child visits become difficult because there are a lot of things like immunizations that are delivered during those visits. So, and kind of a physical exam. I do worry that, we don't really want to undervalue the opportunity to do a physical exam. And speaking to Loretta's point, it becomes, this really was harm reduction, right? The way we rolled this out. But it's often hard to, especially when we're dealing with like infants, remotely on telemedicine fees, it becomes difficult. So no, I just think that we need to roll it out so that the standard of care is good, is great. Right?
I'm going to interrupt there a little bit because we've only got about 12 minutes left now. So in a nutshell, do you want to put it back in the bottle? Yes or no? Just a yes or no? Yes or no? No.
I don't think it can be put back.
Okay, good. All right, Loretta. Loretta, do you want to put it back in the bottle?
No.
Okay. Andrew, do you want to put it back in the bottle?
No.
All right. And Kristen, do we want to put it back in the bottle?
No.
All right. So we all pretty much agreed we're not going to put it back in the bottle. So the question is everything that we've discussed, what does it come back down to? It comes back down to evaluation. A lot of us have done lots of telemedicine. How many of us on the panel have evaluated in any way the telemedicine visits that we've done? Loretta, I'm going to put that question to you first.
So I would say for me personally, I'm sorry to say no, I have not evaluated my personal visits. We have evaluated in our clinic, particularly in our gender clinic, the visits, and those were really well received and well done care.
Okay. Andrew, you've done 600. How many have you evaluated and how have you done it?
400 with surveys. The average score was a 4.7 in terms of my surveys. I had 2 patients out of 600 refuse telemedicine. One almost got into an accident and drove back to Bedford Hospital and had telemedicine. And the second wanted to gamble. That's why she refused telemedicine. We also did 40 new patients with telemedicine. which means that I operated on them without ever touching them until the day of surgery. We looked at patient satisfaction, OR cancellation, complications, length of stay. Nothing was different. The big thing that we've learned is this is a new standard of care. It's no different than when UPMC hired Tom Starzl in the early 80s. I remember when my father was part of that recruiting, or when laparoscopy came around. I think it's up to us to redefine the standard of care. And this conversation is fascinating and very well done. Thank you.
Amy, in terms of, I'm going to come to Kristen in a minute, but in terms of evaluation, evaluation is ethically imperative, isn't it, for us at this stage? Because without evaluation, ethicists, policymakers, providers, we can't decide whether what we're doing is good quality and effective. What do you think, as you know, the leader of our ethics committee at Children's, what would you say is really the most basic evaluation we should all be doing when we do a telemedicine visit?
Well, I do think that this health services research that Kristen Ray has been so much involved in, right? I mean, I think that outcomes or say antibiotic use, which she's published on in during telemedicine visits. I mean, I think that we have to it's going to take a lot of research to look at these. I think what we have generally in practice are these HEDIS measures, which become problematic because generally it means that either an immunization or lab work or something like that is done. So I think it's going to take some time to think about how this. I think though, like patient satisfaction surveys are not necessarily the best way for acute pediatric visits to evaluate that.
Kristen, you've done a lot of work here. I've been helped by you a lot in terms of surveys. Tell me what do you think is the best way for us to evaluate the visit and the product? The whole telehealth product.
Absolutely, and I think that one key thing is I think that all evaluation needs to be to some degree local, especially if we're doing it for quality improvement and quality assurance purposes. But so there could be kind of formative local QA that should be always ongoing, and then there can be more kind of summative national or larger evaluations as well. So in terms of what we've done, and all of this work is very collaborative across lots of groups and lots of people involved. But we started, I think, as soon as April or May, doing some regular weekly evaluation of at least our volume, our diagnoses, our antibiotic use, and our return visits, both planned and unplanned, to make sure we knew what was happening. And those were, we didn't necessarily have a perfect metric of we should be at this or that because this was so new to us, but we wanted to know where we were starting and where things were evolving over time. And so those are some numbers that we have continued to look at on a week by week, over time basis. But then to get kind of a bigger picture understanding of, okay, so what have we, where are we now? I think some key things are looking at quality, and that goes back to questions like, Amy mentioned the antibiotic use. We had published before looking at use of antibiotics in direct-to-consumer telemedicine visits, and so now we're interrogating what's happening with antibiotics within our own practices now, and looking at quality metrics there. And then another place that we've been working, and I have to acknowledge one of our fellows, Dr. Kelsey Schreiberger, who's led this work, is looking at questions of equity and which of our patients within our panels are receiving this care. Are practices that are using telehealth more, delivering care to more equitable kind of swaths of their patient population, and those sorts of questions. And so hopefully some of that will be forthcoming soon in the literature.
Thank you. So I just want to give you my own personal experience. When we had the ramp up in March and April, my division of pediatric ophthalmology, we did about in a period of about 7 weeks, close to 700 telemedicine visits. And we sent out surveys that were set up with the University of Pittsburgh after each one. We only got 62 respondents out of close to 600. And when we asked some of the people who hadn't responded when they came back for a second telemedicine visit, they said that there'd been such a flood of questionnaires from different providers that their children were seeing that they just threw their hands up. So maybe we have to be careful about evaluation fatigue for the parents and the patients as well. There's a question here for you, Andrew. It says, Andrew, great talk. How can the AMA, ATA, and similar organizations help with sustained telemedicine reimbursement on par with face-to-face visits post-COVID? Why is it not so obvious to HHS, CMS, commercial payers that this needs to be supported? Because I suppose this comes into the issue of access, right?
Yes, and CMS just released a rule 36 hours ago, really solidifying a lot of what Trump did with his executive order, and also started to carry forward a lot of the policy put forward in the public health emergency. And there is a lot of positive energy within CMS. And, all politics aside, this administration has carried telemedicine forward in a very powerful way. We also know that the Biden administration is very favorable to telemedicine. There was always the fear of supply-induced demand. If you offer it, everybody will come and raise expense. And there's also concern about fraud, waste, and abuse people are looking at right now. But in general, many third-party payers are putting in very progressive policies, including our own UPMC health plan. CMS, I mean, Varma's quote about the genie's out of the bottle says it. I mean, she's sort of the law of the land, so to speak. It's true, it's up and going, and people really have latched on to that. The state medical boards have made a huge turn and are really embracing it right now. So it's just a matter of time. It's going to take time. I would say in general, telemedicine is harder in an E&M type environment. It's much better in risk-bearing environments such as ACOs, next generation ACOs, P4P, gain shares, and the like. But without a doubt, the feds are on this. Our tweet chat last night, we had the president of the Alliance of Community Health Plans, payers, providers. There were 6 of us last night. And you can, again, follow me on Twitter. And again, messaging the feds, but they really have the message very positive, much more to come. It's great. We have turned a corner and much more to come, all positive.
Ken, can I make just a comment on that? Is that all right?
Yeah, of course. I was going to say, let's open it up to the panel. Please ask questions or comments. All yours.
The point that I just wanted to make, what you were saying about the payers and the legislature folks, basically the PA legislature, being worried that, if we allow telemedicine, more visits, they will come, crashing in. The patients will have more visits. And it's so interesting to me because if the patient needs a visit, they need a visit. And I guess what we need are evaluations to see, do we have better outcomes when patients are having maybe shorter 10, 15-minute telemedicine visits versus missing their twice-a-year appointment in the clinic, right? When patients don't show up, we know they wind up in the ED. But if a patient is maybe having more telemed visits that are shorter, but they actually get what they need, like the young woman who I finally tracked down in her class and we finally could talk about her metformin and what was going on, would it be better for her to present with her, in the ED with all kinds of problems because of her PCOS? So I just find that an interesting statement when people say they're worried about overuse of the system. I would argue that, underuse of the system costs us more in morbidity and dollars because our patients can't come between 8 and 4 every day. In terms of equity, right? We have many of our patients who are working, so telemedicine gives us that flexibility. So that is just my comment on what I think is a very spurious thought put out there by our legislature folks and some of the insurance folks.
Sorry, I keep muting myself. Has anybody got any questions, any comments? because I have tons of, I'm brimming with comments and questions. So please, anybody else on the panel? Kristen, Andrew, Amy, Loretta?
This is Kristen. I would just add to the payer issue that, you know, in pediatrics, because Medicaid is such a large payer for us, you know, when we see these reports come out from CMS, I think we're all often just kind of cheering and hoping that our state Medicaid program will allow all of the changes that we're seeing. But it is a you know, more state by state process for us that involves sometimes some pointing out the degree to which there is excitement and enthusiasm and value. An example would be, you know, storing forward interprofessional electronic consultations, which is now, you know, within Medicare. We're still needing to have that made available to us within our state Medicaid program. And so just, you know, a fact of pediatric care that I wanted to acknowledge.
Andrew, got any comments, any questions? Otherwise, I'm going to keep asking them.
It's amazing how much we're being forced to learn right now. And it's hard, and this is a great panel, Ken. It really is, it's terrific. The most important thing I'd like just to continue to push is that we have to redefine the standard of care as a group here. And a pitfall that we're seeing, and it's worth discussing on this group, it's not that there is no physical examination, it's a different examination. You don't touch, you're using more sight and sound. And that's been a real challenge, just to make sure that we as providers understand that it's a different examination. It's not a lack of examination. And as technology improves, you might see more peripherals that we use, or patients take their own vital signs, or people help to do the exam. And again, this is the whole era of medicine moving forward. And it feels uncomfortable, but so did when we started giving antibiotics or learned about DNA, or started transplantations, or started laparoscopy. It's just cultural change in healthcare. This one's a big one, but again, I think this is a very thought-provoking panel. Thank you, Ken.
I've got. Let's have a look. There's a very good comment in the chat box. It says, would be wonderful if a way to get aggregated entities and trade organizations to ask for important public health mandate to allow for these to continue, and even a no copay type feature across plans, assuming regulatory and legally allowed. Lest the state by state approach is very tough for many families. Would be tough to ignore now that it's been proven to help access. And on that point, Loretta and I were speaking earlier, you know, in the state of Colorado, there are two types of health visits for adolescent health. One where the adolescent has minor consent, and anything that's in that visit is blocked from the proxy parent account. But I don't think we have that in Pennsylvania. Do we, Loretta?
No, and I was literally just about to after Andrew bring this up, what we have in Pennsylvania. Well, for Epic, I can speak about the portals that we have here. So in Pennsylvania, we do not have a law similar to Colorado, so that's that part. But you know, the access issue for our teens, which is an issue for confidentiality, is that when the teen is between 13 and 17, that's the teen proxy, they cannot access the portal themselves to make a My UPMC visit. Their parent has to make it for them. They do not. I wish we had what Colorado has, but we do not. And so that's another confidentiality issue for the teen, and an access issue, because if their parent does not have the teen proxy, if they don't log on and get all that, then the teen can't have a visit with embedded Epic. Right, so that's an issue right there. But in Pennsylvania, there is no specific law, but what we go by is what we have, and what we have is that a teen can consent to certain visits that I discussed, repro health and all the pregnancy and all the things. The things that they can consent to, they have confidentiality for, and so in Pennsylvania, a teen can consent to have these telemed visits as the laws are on the books as of now.
So our time is up, believe it or not. It's been an hour and a half of fascinating discussion. I'm just going to wrap up and say the genie is out of the bottle. We're not putting it back in. I think I want to thank Amy for helping me put this together, Sam Klingerman for really pushing us and organizing everything. Andrew, Loretta, and Kristen, it's been fascinating. To sum up, it's here to stay. We need proper evaluation so we can make sure privacy, access, platform robustness, moral distress for providers are all checked, evaluated, and perhaps there'll be more of these across the country, these digital ethics symposia for pediatrics. Thank you very much indeed. It's been wonderful. Thank you so much.
Thank you, Ken and Amy, for organizing.
Okay, and this is going to be available on the YouTube channel. Sam, is there any housekeeping you'd like to say before we go?
Nope, this recording will be available on the Children's YouTube channel. We did post it in the chat, and it'll also be available on the website you used to receive this information. So thank you, everyone.
Thank you so much, everybody. Thank you so much.